Hello, everyone. I am the Senior Advisor for Rural Health Leadership and Policy at the National Rural Health Resource Center. And we're going to welcome you today for our coalition meeting. We've been meeting as a coalition for more than a dozen years now. And again, the primary purpose of these meetings are to exchange information about both HIT and telehealth. We have, to talk more about how electronic health records are being implemented. We've had a pretty extensive array of topics. And today's focus is going to be upon health information exchange. And our Medicare Flex programs, just as TASK, is funded by the Federal Office of Rural Health Policy. And they're kind of our primary audience here, although we have quite a number of other folks that may not be associated with the Medicare Flex programs. But one of the major areas of emphasis with Flex is on population health. And I think we're all pretty much committed to improving the health of the citizens that live in our rural communities. And health information exchange is so important because it actually gives us data and information about the health of our residents. What we have had in the past has been very incomplete information in that regard. So we know we have high rates of diabetes, for example. In many cases, we may know we have issues related to opioid addiction, et cetera, et cetera. But we've generally lacked the information to take a comprehensive look at patients that might be experiencing those diseases or those conditions, et cetera. So it's going to be absolutely important that we be able to exchange information between our disparate, electronic health systems, that we can take a real 360 view of our patients' experience, really, locate where they might have fallen short of some of their medical aims, et cetera. And I can just tell you, having worked with a number of accountable care organizations, so the ACOs, which are a value-based model, that information lays at the heart of that model. It is absolutely essential that we're able to gather that information and then to be able to initiate initiatives, basically that can address diabetes, et cetera. If we don't have that information, to some degree, we're either flying blind or we only have a partial view of that patient's experience. So I'm extremely excited about the topic today. As we put electronic health records together, and our center was involved as a part of a regional extension center for Minnesota and North Dakota, we basically also had an objective besides electronic health records, being able to exchange information between the different electronic health records, between all the other sources of data information as well. So I believe that's an important topic for our Medicare Flex programs. And consequently, I'm excited about today's agenda. We're going to start off with some updates from TASK, from the Federal Office of Rural Health Policy, and from the Office for the Advancement of Telehealth. We're going to then basically going to look at information exchange overview. My co-chair, Neil Newberger from Health Tech Strategies, is going to kind of provide a very brief overview. Then we're really going to look at rural health information exchange perspectives and direction from the Office of the National Coordinator for Health IT, ONC. And we're really pleased to have some representatives from ONC to talk to us about this important activity. And we will then really profile one of the regional information exchanges. And in this particular case, we're going to look at the state of Nebraska and their regional information exchange. And, again, they've done really impressive work. The reason we're looking at Nebraska is they've done a particularly stellar job of integrating rural health information and really helping our rural providers get a better perspective, again, of patients' information. So with that, I'm going to turn things over to Nicole Clement, who's going to give our task update. Nicole, I'll turn it to you.
Thanks, Terry. Thanks. Hi, everybody. So kind of a bunch from task this time. We have some webinars coming up on February 17th at 2 p.m. Central Time. We'll have the third of this year's 6-part series of telehealth webinars for state flex programs, and that topic is rural telepalliative care and telehospice. And then on February 22nd, also at 2 p.m. Central Time, we'll have Task 90 with the topic of health equity. We have the Flex Workshop coming up at the end of March. So if you have new Flex staff that needs to attend, let us know. And then a couple of other reminders. We are currently accepting nominations for critical access hospital recognition from state Flex programs. So if you have a CAH in your state that has implemented an innovative approach to health equity, consider nominating them for recognition. The deadline for nominations is February 11th, and I believe Kiona just pasted a link to that in the chat. So you can check out kind of what the criteria is related to those nominations. We're also accepting proposals for the 2022 Flex Reverse Site Visit breakout session. So please consider submitting a proposal to share the great work of your Flex program. Those are being accepted through February 16th, and Kiona is going to give us a link for those as well. And then lastly, Flex coordinators, please check your inbox for email from us regarding an update to your state Flex profile on our website. If you had a profile previously, it's really as simple as using track changes in a Word document, and we'll make those updates for you. If you didn't previously have a completed profile, we would really like to have you create one. State Flex profiles are some of the most visited pages on the task website, and they're really a great way to find out who's working on what and how to get in touch with them to learn more about it. So that is it from task. Tori?
Thank you so much, Nicole. Hi, everyone. I'm Tori Leach. I am your Flex Program Coordinator. I am also covering for my colleague, Jenna Cope, who is currently on detail outside of her usual HRSA's office for the advancement of telehealth. I just have a couple updates for you today. The first of which is announcing providerbridge.org, which was created by the Federation of State Medical Boards through the CARES Act and the FORP-supported Licensure Portability Grant Program. This site provides up-to-date information on emergency regulation and licensing by state, as well as a provider portal to connect volunteer healthcare professionals to state agencies and healthcare entities. The second update is part of a 4-part webinar series that will focus on the role of community health workers in team-based care in rural communities and how telehealth can expand these services. This is offered by our HRSA's Office for the Advancement of Telehealth. I will put both of these opportunities into the chat box for you. If you have any questions for HRSA, please direct them towards me, and I will be sure to get them to either myself or colleagues that can help answer your questions. Back to you, Nicole.
Actually, thank you, Tori. I'm going to take it from here and introduce Neil Newberger, who is indicated from Health Tech Strategies. As most of you know, Neil has an extensive background in education and just tons of work he has done in both health information technology and telehealth. So Neil, we're going to turn things over to you and to provide a kind of a background or a little bit of an overview of what we're talking about here with information exchanges, and then you're going to introduce our ONC folks.
You know, Terry suggested that the challenge of interoperability is, you know, just critical now, and I can't imagine a more difficult time in healthcare, and for the confluence of events and the success with which ONC, CMS, and the agencies have gotten us to where we are given COVID and staff shortages and equity issues and closures and everything else, it's all the more important that we have HIE. So you've seen my slides before. I promise I'll only have this one, and I like to give a little bit of context, to the policy, the major policy efforts that kind of got us to where we are. And you can go back 40 years if you're searching and really start with the Federal Privacy Act of 1974. More to the point, I think, we got rolling with privacy and security and administrative simplification regs, given HIPAA in about 1996, along with the Telecom Act, which led us to the Universal Service Access Corporation's provisions, the Snow-Rockefeller legislation, and the discounts for broadband, right? Health information exchange as a concept really came into being around 2001, and the Office of National Coordinator was established in 2004 and has grown ever since. I think there have been 4 or 5 NHIT coordinators since then. Kathy, our friend and colleague, who's the latest, and we thank him for that. We're going to hear from a few more in just a few minutes. Meaningful use came on the heels of the recession and the financial crisis of 2008, 2009, and put up, as you all know, about 35-40 billion with a B dollars for meaningful use of EHR and in terms of incentives, and eventually got us to where we are today. There were some small changes in the Affordable Care Act around the edges. IDESIA gave us risk-based regulatory frameworks for HIT and resultant regs in 2012. And then just a couple months ago, we saw, 65 billion for broadband build out in rural and, unserved areas, which is going to greatly assist, obviously, in interconnectivity, whether it's telehealth or for EMRs or PHRs or remote patient monitoring or for whatever else. And then let me just go back real quick to the 21st Century Cures Act, which was passed in 2016 and led to regulations around, MACRA and MIPS payments through CMS, FDA, software as a medical device distinctions through the FDA, and what's called Trusted Exchange Frameworks in the Common Agreement, or TEFCA, the regulations of which just became final about, a month or so ago. And with those regulations, ONC's hand is, I think, pretty well complete in terms of being able to focus on the Cures Act charges of HIT usability, the conditions of certification, filling out that trusted exchange framework and common agreement, their advisory committees, and the necessary activities so as not to constitute what's called information blocking. So very briefly, what is HIE? The textbook definition, and I'm reading from it right now, is electronic health exchange allows doctors, nurses, pharmacists, and providers, and patients, importantly, to appropriately access and securely share a patient's vital medical information electronically, thereby improving the speed, the quality, the assuredness, and the safety and cost of patient care, all in an attempt to avoid readmissions, avoid medical errors, improve diagnoses, and decrease duplicate testing. And you may hear some of the ONC folks mention these terms. So there are 3 basic: directed exchange, which is the ability to send and receive secure information electronically between care providers to support coordinated care; query-based exchange, the ability for providers to find and or request information from other providers, often used for unplanned care; and consumer-mediated exchange, which is the ability of patients to aggregate and control the use of their own health insurance among those providers, right? And I might ask the ONC folks to just comment on how far have we come in terms of adoption and meaningful use and exchange to this point in terms of any metrics they have. I'm sure it rolls right off the top of their tongue. So that's pretty much on exchange. Information blocking. So that I mentioned that the Cures Act says that certain practices that constitute information blocking are going to be prohibited, right? And those are practices that restrict authorized access, exchange, or use under applicable state or federal laws, such as information on treatment and other permitted purposes under such applicable law, implementing health IT in a non-standard way that is likely to substantially increase the complexity or burden of accessing, exchanging, or using EHI, or implementing HIT in ways that are likely to result in restricting access, exchange, or using EHI with respect to exporting complete information sets, complete being the operative word, or in transitioning between and among health IT systems, or activities that lead to fraud, waste, and abuse, right? And then lastly, there are 8 categories of reasonable and necessary activities that constitute exemptions or exceptions from the information blocking law and therefore the rules. So that's for things like preventing harm if information blocking would otherwise, if not information blocking would result in harm. There's a privacy exception. Okay, there's a security exception, an infeasibility exception, that is if it's not possible to do. There's a performance exception, and just a couple others. So, you know, that's kind of the overview of information exchange and information blocking. With that, let me pull up one more thing, and I'm going to introduce a longtime friend and colleague of both this group and all of ours, somebody who's been around this field forever, and especially given her focus on rural issues and rural HIT, and that's Layla Sami, who's the chair of the Strategic Planning Advisory Committee for ONC and a founding member of ONC's Committee on Diversity, Equity, Inclusion, and Accessibility. So these are obviously, you know, issues near and dear to our heart in terms of the rural work that she does. In fact, from 2012 to 2018, she was the rural HIT coordinator for ONC, and still plays a major subject matter role within the department and within interagency department level rural health. You know, Brock and lots of folks on this call have known Layla for a long time. And Layla, thank you so much, both to you and to Steve Posnack and the others from ONC. We know that it's a busy day because you have your own meetings going on, and we really appreciate, as always, your being with us. Layla, why don't you take it away? Thank you.
Thanks so much, Neil. Really appreciate it. I would like to just defer to our Deputy National Coordinator, Steve Posnack, and Deputy for the Office of Policy, Beth Myers. I'm really so excited to have them speak to this group today. I can't think of any duo that has more depth of knowledge and foresight and expertise. I'm really so excited. Thanks. And thanks for the kind words, Neil.
All right, awesome. I'm assuming thumbs up, you can see the screen. Okay, slides, excellent. It's only been a few years. So as was just mentioned, my name is Steve Posnack. I serve as the Deputy National Coordinator for Health IT at the Office of the National Coordinator for Health Information Technology. I know it's a long name and we all enjoy saying it. I'm joined here by the Deputy Director for the Office of Policy, that's Beth Myers. Say hi, Beth, there you go. All right, so first, just wanted to thank you all for the opportunity to talk with you today, HRSA colleagues as well, those of you in the field. The second thank you is from my wife. I shaved this morning, and she was like, "You must be giving a presentation." So you have her thanks as well. In seriousness, you all are at the intersection of rural health and health IT, and I recognize that at times those two are different languages to be fluent in. The challenges that you face are different, be it from a workforce perspective, from a financing perspective, from a broadband perspective, that Neil already touched on, and overall the resources that you have available to you at different times. Certainly, and most recently, the pandemic has put a lot of stress on our rural communities, and it's a response and landscape aspect that has had a lot of changes to it as well. Telehealth being one of those that I know many of you are engaged in from your work and perspective too. So for the uninitiated, we're going to do a few quick slides. Neil already stole a little bit of our thunder about what ONC is, what we do, what we're focused on right now. And then we'll go through a bit of what I'm calling the greatest hits rendition, a few take-homes and takeaways that will hopefully help you keep our context in mind as you go about your day on a daily basis. So we've got 80 slides, just kidding. And we'll get through it and keep you all on time. I know you've got Jamie as well following after us. So let's take it away. All right. First, I'm move my video screen up there. Here we go. So we were founded, as mentioned, in 2004 by executive order, codified in law as part of the HITECH Act in 2009. So you've got this shift in terms of big statutory moments in our history from an ONC perspective. As was mentioned, the HITECH Act really first promoted and prompted the large-scale EHR adoption that we have now seen over the past decade in the 2010s. That now gets us to, as Neil requested, greater than 90%, 95% of hospitals have electronic health record systems today. Ambulatory is a little bit far below, as you know. There's a long tail in different ambulatory providers out there, but there, I think last count is somewhere in the above 75–80% range from use of electronic health records. So also significantly higher than they were at the beginning of the 2010s when the HITECH Act was passed. Then you fast forward into a bit of the future, 2016, right at the end of the Obama administration, the 21st Century Cures Act was passed. Neil already covered on his orienting slide a bunch of the provisions that are included in the 21st Century Cures Act. I'm going to give you the fast forward version of what's happened in the past 5 years, things you should think about, things you should be aware of coming up from a regulatory compliance perspective. And then Beth is also going to transition into a few big programs that may be right in your backyard or in a neighboring state that you may want to be aware of. All right. So really briefly, if you want to think about the things that ONC focuses on, one is from a technology perspective, which is around standards, how you move that data, how you have it computable, how you have it digitized. The second is around certification, as many of you are familiar. One of our regulatory authorities is around certifying electronic health record technology and other health IT, and that's part of the broader federal programs that reference certified health IT. And the last is around exchange. And for those of you that have been around in the health IT space for the better part of the past, say, 10 or 15 years, as part of the HITECH Act, we had large-scale investments in health information exchanges and state-related efforts, regional extension center programs, and all sorts of other types of infrastructure investments that were part of the HITECH Act stimulus funding to help promote health information exchange. And we've subsequently included policy requirements and, what was used to be meaningful use, as well as other work across the board, be it a combination of all three of these, standard, certification, and exchange, to make forward progress in industry. And as we note here, a lot of our other work, as our middle name suggests, is that we do coordination. So it's working with our colleagues at HRSA, working with our colleagues at SAMHSA, CMS, AHRQ, a number of the other executive branch agencies, including many within HHS, that have mission interests now that intersect with and can leverage that infrastructure that we just talked about, with electronic health records having such great adoption and saturation now in the marketplace. Whoa, somehow I zoomed in. That's new. Weird. Show goes on. So what are we focused on? Top 5 things of how to boil stuff down. First and foremost, COVID response. A lot of work coming out of both some statutory changes as well as executive orders from the Biden administration in terms of moving the public health system, which I know you all are engaged in as well, to support our transition and data modernization from a public health perspective. We are also focused on an ecosystem that involves what are called application programming interfaces, APIs. Some of you, I'm sure, are familiar with the FHIR standard, Fast Healthcare Interoperability Resources. That's an API-based model of exchange. And that is one thing that we think will have a leveling impact as well for rural communities too, as we start to get more and more into a modern standards landscape that will hopefully increase connectivity and reduce some of the expenses that are, that many have experienced over the past several years. Number 3, key to our discussion today, expanding health information exchange networks and supporting the broad spectrum of stakeholders that may be engaged in those activities. One of the things that's key to this administration right out of the gate has been a focus on equity. Our national coordinator, as was mentioned, Dr. Mickey Tripathi, is focused on what we can do from a health IT perspective and really looking at how we can build in that health equity thinking by design. And then lastly, as I mentioned, coordinating with a lot of our federal partners in terms of their health IT activities and really using that cumulative investment and coordinated approach from a federal government perspective. Okay, so briefly, timelines always help. As was mentioned, we did issue a rulemaking in 2020 to set up both new certification requirements as well as information blocking requirements. The key deadlines that I just wanted to highlight here, one is already passed, which is the applicability date for information blocking. And that applies to healthcare providers, of which many, critical access hospitals, rural hospitals, et cetera, are going to be covered. That applies to developers of certified health IT, and that also applies to health information networks and health information exchanges. We have a wealth of resources on our website. The team gives our 90-minute long presentations, and so in the time remaining, wanted to make sure that myself and Beth have a few other things that we wanted to call out to your attention. The other thing that I highlight here at the top of the timeline has to do with the expected rollout of new capabilities that are part of our certification program and for which health IT developers are responsible for delivering. And so that includes a new certified API that references the FHIR standard, as well as specific data, which we refer to as the U.S. Core Data for Interoperability. So if you see the US CDI acronym, that's the set of data, that's that core set of data that must be part of those certified APIs and able to be exchanged via those APIs, as well as for information blocking purposes altogether. So that's I didn't do too much justice to the entirety of all these policy requirements, but those are really a couple bottom lines that I wanted you to keep aware of this year, as well as leading into next year, really busy years from a compliance perspective, and when we expect to see some change and cycle through in the market. Okay. One thing I also wanted to call your attention, given that we do have some data on this, and you can go to healthit.gov/data, which is where we have our data briefs. We have done through partnerships with the American Hospital Association and other survey and statistical oriented agencies some work to better understand rural hospitals and the rural ecosystem in comparison to urban, in this case, for some of the bullets. And so we have found some differences, which probably for you all, you're like, duh, no kidding. There are definitely differences. We see them every day. Some of the ones that I wanted to, call to your attention, are the participation in health information exchange. And so, that's both cost, connectivity, and standardization aspect dynamics. And Beth will, as we transition to the slides that she's going to cover, we've now been starting to implement, as a result of the 21st Century Cures Act, some changes in the landscape overall that we think will have benefits and advantages to the rural health IT community. The other thing that we found as well, getting to this last bullet, is that there are some differences in terms of patient access and patient engagement. And that may be another thing that you want to take a look at as you receive, cooperative agreement or grant money from our federal partners and the types of health IT investments that you make to keep an eye out for ways in which you can enable greater patient access as well. So with that, I'm going to keep driving the slides. Beth will say next, and I will turn it over to her to talk TEFCA. Go ahead, Beth.
All right. So TEFCA, super exciting, big acronym, really big concepts behind the big acronym. This is from the 21st Century Cures Act, the Trusted Exchange Framework and Common Agreement, affectionately called TEFCA because it's a great acronym. You may have been following this to some extent. For those of you who have not, this has been multiple years and multiple iterations to get to the point that we are at now. We actually put out a draft version several years ago, got lots of public comment on it, and there's multiple pieces to it. And this is what it's important to understand from your perspective, because as Steve mentioned, we're seeing a lot of movement on the actual adoption of technology. And over the next year, we expect to see even more movement on the adoption of some innovative technologies like application programming interfaces, the expansion of the USCDI dataset. Those are going to facilitate the actual technical capability to get the data and have it be able to talk from one EHR to another. The issue then becomes, how are you actually making those connections? So this is one of the things that we try to address with TEFCA. So there is a recognized coordinating entity, that is Sequoia. They are the ones who are responsible for essentially day-to-day operations of the TEFCA. What it is a set of a couple of things. First, there's some core principles, and these are core sort of policy / business / transparency / technical. There's multiple aspects to them, to the core principles for health information exchange and how we believe that it should work, not just within a single system or within a single network, but network to network, so that what we're trying to do is sort of create a federation, you might say, of networks that can all talk to each other, and that there shouldn't be any difference between when you're pulling data or moving data or using data within a system to when you're using it across systems, across state borders, across regions. We want to see those current barriers sort of dissolve and make that seamless no matter where you are. So there's some principles based on that, and that is sort of the fundamental core piece to it. And then it has some business principles and contract principles, what are called the minimum required terms and conditions. So those particular pieces are pieces that are essentially contract pieces that allow for this to establish trust and for networks to resolve what they might have that are current differences about things like data sharing authorizations or roles for who's allowed to share the data and how that works, and to try and resolve those issues between them so that those contract terms can create a trust environment where that information can flow, no matter which network you're talking about and no matter what their own existing terms and conditions might be. And then the third piece to it is a technical framework. And that technical framework, you can see the acronym in the middle, the QTF. That technical framework is for the QHINs. That's the sort of top level of the umbrella or the top level of the network that may have other networks under them that feed into them, who are responsible really for creating that infrastructure that allows it to go across. So that QTF, that technical framework, the QHIN technical framework, are sort of the minimum technical requirements and technical specifications. So it's those three pieces working together. It's policy concepts that we're all agreeing that this is how this needs to flow, this needs to work, it needs to be seamless. It's contract terms and business terms that allow for trust to happen. So we eliminate those artificial or abstracted business barriers to information moving, and then it's establishing this core technical framework. So what it should mean for all of you is that as you have systems that are in place that actually have these standards available, they can actually start to talk across networks without having to join 50 different networks, the network that you are already a part of or that you may already have access to. If it moves into TEFCA and it participates in the network, in the broader network, they'll be able to connect. So when you have, because again, remember these things, we'd love for them to just be a regional problem, but it's not just a regional problem. You may have, when you're thinking about telehealth solutions and you're trying to use services where a lot of states have done waivers so they can get telehealth participant across state borders and use providers who may not have been licensed in their state to support state care, care in their state, especially during the pandemic. This helps to facilitate that actually working, because then maybe their primary care home doesn't have telehealth services, but you can leverage another aspect or another platform, and that provider can then actually connect. So it makes some of these solutions that in rural communities are absolutely essential to ensuring access to care can actually happen and can actually have the same robust data that you might have who someone is always in their own network in a more complex urban setting or a suburban setting where that network is covering that range of providers in that network already. So we're thinking that this is going to be really, really a big opportunity and a big difference maker. So I spent most of my time on it, but we're going to go on to a couple other programs as well that we think are going to be some key things that you might want to pay attention to. The first one is PHIT, another excellent acronym, which is the Public Health IT Workforce Development Program. This is a major initiative that we have launched with several educational consortiums. Each of the consortiums actually has to incorporate several key factors into an education curriculum, and that education curriculum is explicitly designed to help increase the total number of, diversity of, and knowledge base of our public health workforce. And when we say public health, everybody right now, because of COVID, is thinking, public health and epidemiology, but really public health trained professionals work in all aspects of healthcare. They work in home and community-based services, they work in healthcare facilities, they work in our office, and that is a huge need to try and get more public health centric training that includes technology and includes how technology can work to facilitate public health exchange, clinical information exchange, the connections between things like home and community-based services and clinical information, but also things like, we need people on the ground to understand public health and understand how something like a health information exchange network should work. So that is the goal here. You should see if there's one in your state. We have it available on our website. You can take a look. If you don't have one in your state, we are also hoping that this program can serve as a model for others to implement consortiums in their states that are looking specifically at underserved populations, looking specifically at underserved regions, and making sure that we're getting public health trained folks who are also informaticists and also understand technology. So we think this can be a great model. You should check it out, see if you can participate in your state, maybe hire some of the graduates or put them on fellowships or internship programs at your facilities, but also think about if your state isn't doing it, is there something that you can do with the institutions that you might already work with that could take this model and make it work for you there as well. Next slide. And this slide and the next one both have a whole lot of detail on another program that we're pretty excited about. Again, this is an example program, and it's a model of the types of things that we've been really excited to be able to do. And if there are things that you see that need to happen, and that you have funding opportunities that you want to connect with us about to see how we can incorporate health IT policies, standards policies, and really take advantage of these opportunities that, TEFCA, the technology itself, the certification program, application programming interfaces, all of these things that are happening now. And even our partnerships with places like CMS and CDC to make those things happen. We would love to help make that model expand and help it help your programs as well. So there's my shameless plug for that. Please call on us. We are a service-based organization. We are the national coordinator. That part's important in our name. But the other program that I wanted to highlight really quickly is the STAR HIE program, which is again a funded opportunity that we were able to put out. There are 21 state HIE type organizations. Some of them are regional. That are participating. So again, it may be something that is available in your state. It may not, but take a look at our list and see, because it is another thing that is also hopefully repeatable. The entire purpose of it is to get some essentially startup capital and startup technical assistance going to build better infrastructure connections for public health agencies and for public health information sharing, leveraging health information exchange organizations and their existing networks. In each case, there are some specific pieces that we've been looking at. For example, provider burden is mentioned here. Some of the states or some of the organizations, because again, sometimes it's organization-led, sometimes it's state-led, sometimes it's both. They are looking specifically about how to try and reduce burden on providers for reporting, but also public health for getting good and rich data. This program actually also incorporates specifically some COVID response pieces. Steve, if you want to go to the next slide. So some of the projects are specifically looking at how to get COVID lab data or COVID immunization data made available for public health, how to aggregate it and leverage the connections that the Health Information Exchange already has to make the public health information that the state registry has more robust and fill in things where there might be gaps. There are vaccination tools that have, or vaccination reporting tools that have been built by some of the participants in the program. There have been new connections that allow for bidirectional exchange, maybe between labs and health information networks that are incorporating demographic data that isn't actually always available in lab systems. So there's some really exciting different things happening here. If your state isn't doing one of those projects and is doing another one of those projects, there is sharing that is going on between them. So they can kind of see this is working, this isn't, this may be reapplicable. And in each case, the work that's trying to be put in here is to try and move the needle on that specific use case, but they're also trying to identify how that could be a reusable infrastructure change, or how that could be a reusable connection or a lessons learned. And we're working right now on taking some of the lessons learned from this and creating educational resources that can be done by people who haven't participated and can be taken by those organizations and say, well, maybe this was solving this one particular piece to how to get lab data to the public health agency, but we could be using this for childhood immunizations as well, or we could be using this for how we're thinking about where our PDMPs are doing interstate connections. So there's a lot of great lessons to be learned here. And again, we'd love to see how this could be taken to the next level and how others could sort of step in and fund the next piece as these continue to move forward, because again, this was COVID specific funding, so it is somewhat limited in its total scope, but we expect that it can continue to grow. So I have now gone exactly 35 seconds over according to my watch, but I will stop there. And thank you all again for this opportunity to connect with you about some of these things that we're doing. And Steve put his on, but mine should also go on there, and I'll put it in the chat. And we are obviously available for any follow-up. We would love to see where we can help to facilitate any of the initiatives that you all may want to take on.
Yeah, thank you very much, Steve and Beth. We really appreciate this. I really admire your positivity and enthusiasm, and it's just really an encouraging sort of direction here. So we so appreciate you coming today. And if you do have questions, please put them into the chat. We're probably not going to have a lot of time to answer them, but we will get them answered for you, either if we have an extra time here, or again, we will get back to you through email if it takes a little bit longer than that. So I want to move on and really put some focus now on one of the state initiatives that we've been extremely impressed with. I'm going to introduce Jamie Bland of Sync Health, who's from Nebraska. She is a doctor. She has a doctor of nursing practice in public health. As a nurse, she's also the CEO, Chief Executive Officer of Sync Health. She was appointed in 2018. This is an organization that has grown really rapidly. One of the things that I find very impressive is they put together a prescription drug monitoring program to include 3 new entities, and to include Sync Health Advisors, the Sync Health Foundation, and the Nebraska Healthcare Collaborative. In addition, the Iowa Information Network, IHIN, recently joined Sync Health. So they're now working in both Nebraska and Iowa. And just in terms of just the drug events, the adverse drug events, I just saw data, the 700,000 emergency room visits. I mean, this is disgraceful in its own sense. We desperately need more information and be better at drug reconciliation as well. So Jamie, I'm going to turn things over to you, and you tell us about your programs, because as I've said, we think they're incredibly impressive.
Thank you. And can you see my screen, my slides? Okay.
We can, yeah.
Okay. So I'm going to jump right into our journey of the Health Information Exchange. You know, if we've done anything right, it's the COVID-19 public health response, and a lot of our acceleration and adoption is related to that need for information and how we've been able to partner with public health. We are a public-private partnership, and we talk a lot about the health data or the Health Information Exchange as a utility, and that we have generators of information and consumers of information. And in the middle, we need to transmit and distribute data that is useful and in context for the clinician on the other end. As I was introduced, I was a provider. I know the challenges of looking for data I grew up in rural North Dakota. I've practiced in critical access hospitals. I understand a lot of the challenges that folks face in the rural environment, which is why we've really taken an approach to interoperability to be very broad in our application of health information exchange. The prescription drug data as introduced is all dispensed medication in the state. So we have a very comprehensive, and when I show you some statistics on utilization later in my slides, you'll see how that's been adopted. And I think where we put a lot of effort is in the trust and reliability of the data and the systems. There's nothing that's black box for us. And we really meet providers where they're at. If you just need the HIE connection and that's what you want, great, we'll do that. If you have IT show up to your rural health clinic or your critical access hospital once every 2 weeks for 4 hours, we'll be there to help you in your interoperability journey and apply some technical resources that aren't otherwise available for you. That's really where we've learned to be quite extensible in our rural footprint. And we cover from the panhandle of Nebraska to the Mississippi and Iowa. So if you drove from one end to the other of our geographic footprint, it would take you about 16 hours. So it's not a small footprint, it's quite large. And we encounter all kinds of use cases, from frontier clinics to critical access hospitals to academic medical centers. So the variation of use cases requires a broad application. When we speak about health information exchange and the health data utility, we talk about exchange as a verb, and the utility is really the noun. And when we are looking to apply this in Nebraska, we've had some very fortunate things happen for us, including some policy advancement. The prescription drug monitoring program, it sure happened in the context of the opioid crisis, but it was a very broad application in a patient safety perspective that we needed all medication, right? Like, opioids were a problem, but what is the broader context that brings us to the need for information? And with some very candid conversations and some, brute force at times, that policy was able to be adopted in Nebraska, and we started collecting all medications as of January 1, 2018. So as I came into the organization, we had some of these initiatives kicking off, and prior to that, I was really a consumer on the other side. Had a lot of comments to share about what I wanted to see in the health information exchange and what would be useful for me as a provider. So they invited me into the organization. That journey's unique in its own. So how did a nurse get to lead a health information exchange? That's a unique application as well. But I think Shyla Blend is also on the phone, a very similar background to mine, and is also leading the North Dakota HIE. One thing that we really started to understand with the connectivity and the pharmacy components is that that broad application of data, we needed the social care information. So what information was happening outside of the bricks and mortar of the hospital? Could we connect the community? How could we work with United Way? So we began our social care journey in late 2019, and we have two very robust statewide infrastructures for community-based organizations to also share data. We have independent labs, the pharmacies, of course. We now are onboarding claims data and going back to some of our original connections and enhancing the data to this US CDI standard. So if your connection was done in 2015, there's a lot of modernization that may have need to be happening in the different data needs, the public health feeds that are currently being modernized. And we often help the rural providers with those compliance requirements, whether it's the Promoting Interoperability Program or the MBQIP program as an example. We were able to automate some of the output of data from the EHR so that those dashboards could be visible to the Office of Rural Health. Those are the kinds of things we help rural health providers to be able to participate in alternative payment models or population health related activities as part of our mission. One thing that we've been able to really leverage to support that kind of assistance is that we have robust Medicaid, public health, county health department, and we have a fairly robust presence with the policymakers to help them understand what are the needs of the rural health providers in the context of interoperability. When new compliance requirements for public health reporting come down, what do we need to provide as a state, and what do we need to expect will be challenges from a rural health provider's perspective? We work with all kinds of EHRs. One thing that rural health providers leverage with us is our ability to gain audience with electronic health records. One of the things that we know that they encounter on a frequent basis is the challenge to actually be prioritized as a project, right? So we're able to leverage our relationships across the broad electronic health record footprint. So this is our health data utility in practice, and this is average monthly returns. Of course, there's higher and lower months. But when we talk about utilization and some of the stops and starts with HIE across the country, it's been in the adoption and utilization, the ease of access, the ability to easily get to the data. So one of the things that we focused on is really that clinician experience. How can we be frictionless? How can we push the adoption of APIs? Can we deliver files? Can we, what is the easiest route to accessing information? And you'll see that in our numbers, right? We have, 2017, early 2018, we were in the 7,000 to 10,000 a month query numbers. And with the robustness of data, so the more that we were saying, hey, we have all hospitals, we have 70% of skilled nursing facilities, we have all pharmacies, we saw our numbers coming up because there was an increased trust and reliability in the information. And that if they were going to query a platform or receive a file, they could have great confidence that the data they needed was in that information. So one of the things, with the 2.6 million queries, we have 1.9 million folks in the state of Nebraska. So that means providers are checking that PDMP quite frequently before prescribing or using it as a medication reconciliation tool so that we're avoiding some of the adverse events from over or under prescribing. HIE, 1.6 million queries a month. That's a big number, right? I mean, we're doing a lot to push the APIs, single sign-on. Again, those number of experiences that help folks access information. So it's not clunky, it's not cumbersome. And these are tools that are sometimes out of reach for rural health providers, right? To invest in the API or to invest in some of these single sign-ons, we really need the assistance from the Medicaid or seeking a grant to make sure that these types of population health related ease of access tools are available. And then things that we then re-leverage with public health. So the fact that we have a robust HIE and PDMP, and we're able to leverage the demographics data that we had in those systems to enhance and speed to value type of activity with contact tracing. We're able to do that from the beginning of the pandemic. Contact tracing demographics, patient matching for immunizations data. We've had over 19 million notifications across the geography for different contact tracing, leveraging the infrastructure. I'm going to stop there because I know there's only a few minutes left if there's any questions.
Thank you, Jamie. And again, the depth of the work that you do is really extremely impressive. So we're going to suggest that our Medicare Flex programs reach out to the regional information exchange that may be locally, particularly as we're moving into value and population health. This information is so important in that regard. We are kind of at the end of our time. I would refer you to the chat where Steve has answered a question if you're looking for just a little bit of further discussion on this. But I'm also going to suggest that you do some post polling here. Give us a feeling for how you're feeling about the health information exchange, concerning your knowledge and concerning just basically, if you have any other questions as well, do feel free to direct them to task, send them to Nicole, and she'll be able to send them to our speakers as well. So again, I want to thank everybody that's participated today in what I think is an extraordinarily important aspect of our American healthcare system. As we noted before, do stay tuned. Our next session at the Center on Telehealth is going to focus on hospice and palliative care. And this is another, to me, extremely important aspect that I think is going to help resolve some of the issues we have in terms of getting those services out to rural America. So with that, please fill out the poll, and I will bid you all goodbye.